Welcome to the weekly neurology deep dive. Today, we're diving into neuropsychiatric symptoms in Parkinson's disease. Our source is a recent narrative review from Therapeutic Advances in Neurological Disorders. And our mission, as always, is to pull out the key practical insights for you, focusing on diagnosis, management, and research relevant to daily clinical practice.
And just a quick but important note before we start, this deep dive is purely for educational purposes. There's no commercial goal here. It's really just a summary of the source paper. We strongly recommend reading the full article for the complete picture.
Great, so let's jump in. The review really emphasizes this shift in thinking about Parkinson's disease. It's not just a motor disorder anymore, is it?
Not at all. The non-motor symptoms are incredibly prominent, and the pathology we now know extends well beyond just the nigrostriatal dopamine pathways.
Which brings us squarely to neuropsychiatric symptoms. These are described as being very common.
Extremely common, and they have a huge impact on quality of life, not just for patients, but profoundly for caregivers, too. The review highlights that these symptoms can pop up very early, sometimes even before the motor signs, in the prodromal phase.
And as the disease progresses, these neuropsychiatric symptoms often become, well, the most disabling aspect for many people.
That's right. They're major drivers of reduced quality of life, caregiver burden, and unfortunately, sometimes they lead to needing nursing home care.
So early detection and assessment become really critical then.
Absolutely essential. They inform our therapeutic approach, give prognostic insights, and help families prepare.
And the underlying reasons are complex, involving dopamine systems, sure, but also many non-dopaminergic pathways.
Which is precisely why treatment is so challenging. The review points out that our options, both drug treatments and non-drug approaches, are still quite limited.
The evidence base isn't always strong for what we do use.
Exactly. It often comes down to clinical judgment and tailoring therapy to the individual. This review does a good job of summarizing that current state and, importantly, where the research gaps are.
Okay, let's break down some specific symptoms. Starting with cognitive impairment, the review describes a spectrum. Parkinson's disease, subjective cognitive decline, then Parkinson's disease, mild cognitive impairment, and finally Parkinson's disease dementia.
And the numbers are stark. About a third of patients might already have Parkinson's disease mild cognitive impairment, PDMCI, at the time of diagnosis. And over the course of the disease, up to 80% might develop Parkinson's disease dementia, or PDD.
80%, that's significant. And the pattern typically starts with those frontostriatal issues: attention, working memory, planning.
That's the common early pattern, yes. Later on, especially with PDD, you see more posterior cortical problems: memory, language, visuospatial function.
Pathophysiology is complex: proteins, genes, multiple neurotransmitters beyond dopamine.
Very complex cholinergic deficits, the way pathology spreads. It's all involved, particularly in the progression to dementia.
So what about pharmacological treatments for cognitive issues? How limited are we talking?
Extremely limited, unfortunately. We only have symptomatic options, nothing that modifies the disease course itself. For PDD, Parkinson's disease dementia, rivastigmine is the only treatment with demonstrated benefit. It's rated MDS evidence-based medicine, clinically useful. Other acetylcholinesterase inhibitors like donepezil or galantamine are considered possibly useful.
And for Parkinson's disease, mild cognitive impairment, PDMCI, that intermediate stage.
That's a major unmet need. The review states clearly that trials with rivastigmine, rasagiline, atomoxetine, donepezil, none have shown clear symptomatic benefits for PDMCI.
But there's research ongoing. The review mentions several trials looking at novel targets.
Yes, quite a few. Things like sigma-1 receptor agonists, deamino acid oxidase inhibitors, hepatocyte growth factor system modulators, NMDA receptor modulators. Even donepezil is being retested in larger groups, specifically for PDMCI. There are several clinical trial numbers listed in the paper if you want to look those up.
Okay. And outside of drugs, non-pharmacological approaches?
These are absolutely crucial. First, avoid medications that can worsen cognition. Think anticholinergics, sedatives. That's basic but vital. Also, managing comorbid conditions effectively, things like orthostatic hypotension, small vessel disease, sleep problems.
What else can we advise?
Well, cognitive stimulation, social engagement, these are important. And physical exercise, it's always a recommendation. It consistently shows benefits across the board in Parkinson's, including cognition. Non-invasive brain stimulation looks interesting, but it's not quite ready for prime time clinically. And there's early work on stem cells for PDD mentioned too.
Right. Let's shift to psychosis in Parkinson's disease, or PDP. The review talks about a spectrum here too: illusions, hallucinations, delusions.
Yes, and minor hallucinations, usually visual, are surprisingly common. The review says over 40% of patients experience them, sometimes even before diagnosis.
And they can become more complex over time.
And they often do, particularly in patients who also have PDD. Delusions can occur too, sometimes on their own. The underlying biology seems to involve disrupted network connectivity, attention networks, default mode network plus cholinergic system degeneration, and changes in serotonin receptors like 5-HT2A and 5-HT3.
How do we manage this? If symptoms are minor, maybe no treatment.
Exactly. If there's minimal impact, watchful waiting might be fine. But if intervention is needed, the first step is crucial. Rule out triggers. Think infection, delirium.
Then medication adjustments.
Yes. The general principle is to carefully reduce dopaminergic stimulation and, where appropriate, consider enhancing cholinergic tone. The review suggests a specific order for reducing dopamine meds. Start with anticholinergics, then selegiline, dopamine agonists, amantadine, COMT inhibitors, MAOB inhibitors, and levodopa last. Also, try to stop benzodiazepines, opioids, other psychoactive drugs if possible.
If that's not enough, we move to specific antipsychotic type medications.
Correct. Atypical antipsychotics are the mainstays. Clozapine is MDS evidence-based medicine clinically useful. Quetiapine is rated possibly useful, but practically speaking, it's the most prescribed, often due to monitoring requirements for clozapine. Ziprasidone and aripiprazole are alternatives. Critically important. Avoid haloperidol, risperidone, and olanzapine. High risk of worsening motor symptoms.
Are there non-antipsychotic options mentioned?
Yes, enhancing cholinergic function with rivastigmine is helpful and safe, especially if PDD is present. And pimavanserin, that selective 5-HT2A inverse agonist, is also MDS evidence-based medicine clinically useful. It showed good results for psychosis without hurting motor function, though its availability can be an issue.
Any research highlights here?
There's some older evidence, and a current trial for 5-HT3 antagonists like ondansetron. A drug called ulotaront also showed potential in a pilot study. Other trials are ongoing too.
And non-pharmacological strategies for psychosis.
Simple things, really, but important. Ensuring good lighting, correcting vision or hearing deficits, maintaining regular sleep-wake cycles, a supportive home environment. These complement any medication strategy.
Okay, let's talk depression. One of the most common NPS affecting, 35 to 50% of patients?
That's the range, yes. And often it shows up before the motor symptoms. Interestingly, unlike apathy or cognition, depression tends to remain relatively stable over the disease course. Risk factors include general ones like age, female sex, prior depression, but also PD-specific things like higher levodopa dose, bad motor fluctuations, autonomic problems.
Pathophysiology is complex. Again, psychosocial factors, neurobiology involving dopamine, serotonin, and noradrenaline.
It's multifactorial, but the review makes a strong point. Because depression has such a big impact, it should be actively treated, regardless of how severe it seems.
Pharmacologically, what are the options? SSRIs, SNRIs, TCAs?
Those are the main classes investigated. But the review notes a real lack of large head-to-head trials in Parkinson's disease. So the choice is often pragmatic, based on side effect profiles and clinical judgment. SSRIs like citalopram, sertraline, paroxetine, fluoxetine are rated MDS evidence-based medicine possibly useful. Need to be aware of potential, though less than 5% risk of worsening tremor or Parkinsonism, and the serotonin syndrome risk with MAOB inhibitors. Generally, sertraline, citalopram, fluoxetine might be preferred over paroxetine because paroxetine has stronger anticholinergic effects.
What about TCAs and SNRIs?
TCAs like nortriptyline, disopramine, amitriptyline are also possibly useful, but their side effects, anticholinergic, cardiac, often limit their use in our patients. For SNRIs, venlafaxine is the only one classified as MDS evidence-based medicine clinically useful. Some evidence suggests these dual-acting agents might even be better than SSRIs and PD, but more research is needed. Other antidepressants get used off-label but lack specific PD evidence.
Can adjusting dopamine therapy help depression itself?
It can, particularly earlier in the disease. Pramipexole is actually rated MDS evidence-based medicine clinically useful for depression in PD. But you have to be really careful because pramipexole significantly increases the risk of impulse control disorders, especially in patients who are already depressed. Rhodocaine and ropinirole have shown inconsistent results for depression, and MAOB inhibitors have limited evidence here.
And non-pharmacological for depression.
Cognitive behavioral therapy, or CBT, is the most widely used psychotherapy and is MDS evidence-based medicine possibly useful. It can even be delivered via telemedicine. The review suggests considering it first line, either alone or with antidepressants. Brain stimulation techniques are also relevant. High-frequency repetitive TMS over the left prefrontal cortex seems to have short-term benefits, rated possibly useful. Deep brain stimulation, DBS, effects are mixed. STN-DBS seems generally helpful if targeted correctly. Maybe GPI-DBS is even better, according to some studies. And electroconvulsive therapy, ECT, is effective for severe resistant cases, but it's usually reserved due to potential side effects. Don't forget lifestyle things, too. Physical activity, mindfulness, yoga, all show benefits.
Right. Anxiety next. Another really common one. Over a third of patients.
Yes, affects a lot of people, often precedes motor symptoms, and crucially, it frequently ties into non-motor fluctuations. That's a key clinical problem. Huge impact on quality of life, caregiver burden. It's rightly a high research priority. Pathophysiology involves a wide network, with serotonin deficiency often implicated, but the link to fluctuations clearly involves the dopamine system, too.
So pharmacologically, what does the review suggest?
Well, the first-line recommendations often come from studies in the general population simply due to lack of PD-specific data. So SSRIs or SNRIs are typical starting points. Alternatives might be pregabalin, TCAs, buspirone. The review strongly cautions against routine use of benzodiazepines or quetiapine for anxiety because of dependence risk, poor tolerance, and increased falls. Pramipexole might be considered. But the most important point, perhaps, if anxiety is clearly part of a non-motor fluctuation, off-period anxiety, optimizing the dopaminergic therapy is usually the most effective strategy.
It really sounds like specific evidence for anxiety treatments in Parkinson's is lacking.
That's exactly the problem highlighted. Most drugs haven't been rigorously tested in randomized trials just for anxiety in PD patients, so we're often extrapolating, which isn't ideal given potential differences in mechanisms or tolerance. There's currently only one phase 2 trial using mirtazapine, specifically targeting anxiety in PD.
Which makes the non-pharmacological approaches even more vital here.
Definitely. Given the limited drug evidence and side effect concerns, CBT again shows efficacy, even demonstrating brain changes on imaging in PD patients. Involving caregivers seems helpful too. Exercise again, always recommend it. Significant impact. There's growing evidence that STN-DBS might improve anxiety, especially stimulating more ventrally, but results vary. And things like mindfulness, non-invasive brain stimulation, they show promise but need more solid research.
Okay, let's tackle apathy. Defined as that decrease in motivation, separate from cognition or depression, though they often overlap.
Right, prevalence is high, maybe 35 to 70%. Can also predate diagnosis. Big impact on quality of life, functional dependence, caregiver stress. Pathophysiology points towards issues in basal ganglia circuits, reward pathways, and deficits in dopamine, serotonin, and acetylcholine.
Treating apathy pharmacologically sounds particularly tough, according to the review.
It is very challenging. The evidence base is really thin. Only 2 drugs are listed as MDS evidence-based medicine possibly useful: piribetal and rivastigmine. Piribetal, a D2D3 agonist, showed some benefit after STN-DBS in one study. Other dopamine agonists like pramipexole and ropinirole have shown some positive effects in studies with weaker designs. Rivastigmine showed benefits specifically in patients who didn't have dementia or depression.
Any other potential leads mentioned?
Small studies hint that methylphenidate or candesartan might be useful. Safinamide showed a positive trend in a post-hoc analysis, suggesting it needs more investigation. Interestingly, SSRIs and SNRIs haven't really panned out for apathy.
And non-pharmacological for apathy.
Also limited evidence, though promising. Things derived from CBT, like exercise or behavioral activation, show potential. But it's hard to know if it's a direct effect on apathy or just improving mood or function generally. The review also notes that STN-DBS can sometimes worsen apathy. This might be due to reducing medications afterwards, or maybe a direct effect of the stimulation itself. But the studies looking at this are quite variable and not always high quality.
Finally, impulse control disorders, or ICDs, primarily seen as a side effect of dopamine treatments, especially dopamine agonists.
That's the main view, yes. An inability to resist urges leading to repetitive behaviors despite harm gambling, shopping, hypersexuality, binge eating, sometimes excessive hobbying, punding. Related issues are dopamine dysregulation syndrome, often linked to high pulsatile levodopa doses.
How common are these?
Disturbingly common, affecting somewhere between 20 and 45% of patients on dopamine therapy. They can start years into treatment and often become chronic, hard to manage just by cutting back the dose. Risk factors include being male, younger onset, longer disease duration, having apathy or depression, smoking history, personal or family history of addiction. Pathophysiology involves sensitization of D2, D3 receptors.
Management sounds like it relies heavily on clinical experience.
Very much so. There's a lack of strong trial evidence, so consensus is tricky. But the first step is clear. Gradual reduction of the dopamine agonist, and the emphasis is on gradual. The review warns strongly about dopamine agonist withdrawal syndrome, which can cause severe anxiety, depression, cravings, insomnia. You need careful monitoring. Abrupt stopping is not advised.
If reducing the agonist isn't enough or feasible.
Then you might need to consider reducing levodopa or other dopaminergic drugs like MAOB or COMT inhibitors. For dopamine dysregulation syndrome, or punding specifically, strategies include lowering the total levodopa dose, splitting doses more frequently, or trying extended-release levodopa.
Are other medications sometimes added on?
Yes, but the evidence is weak. Amantadine and naltrexone have been tried, but results are conflicting or side effects are problematic, so they aren't generally recommended. Pimavanserin is being studied specifically for ICDs in a current trial. Experts do sometimes use clozapine or quetiapine off-label as adjunctive therapy in difficult cases, but this is based mostly on case reports. The role of SSRIs is quite controversial. Some observational data links them to increased ICD risk in PD, but outside PD they can help compulsive behaviors, so uncertain.
Does changing formulations or using device therapies help?
Maybe. Switching from immediate to extended-release dopamine agonists might provide more stable stimulation, but that needs proper study. Levodopa-carbidopa intestinal gel, the pump, has been associated with reduced ICDs in some studies, which fits the idea that continuous stimulation might be better.
Non-pharmacological approaches must be key here too.
Absolutely essential. Having committed caregivers involved is probably the single strongest predictor of remission. Addressing the fallout legal, financial problems requires social work involvement. Assessing insight, capacity, other psychiatric issues is also vital.
Is there a role for psychotherapy for ICDs?
CBT is rated MDS evidence-based medicine, possibly useful. This is based on a single study, but it did show significant improvement.
And DBS, how does that affect ICDs?
Most studies looking at bilateral ST and DBS find that ICDs tend to decrease afterwards. But this is thought to be mainly because patients can usually reduce their dopamine medications significantly after surgery, rather than a direct effect of the stimulation itself. Results for unilateral STN or GPI stimulation are more mixed.
Okay, so stepping back, the review paints a picture where we've gotten much better at recognizing these neuropsychiatric symptoms, but treating them effectively is still a major challenge.
That's really the core message, isn't it? Our diagnostic tools are better, we understand the impact more, but the management options are often modest, especially later on. Pimavanserin for psychosis was a step forward, avoiding motor issues. But for cognition, treatment hasn't really changed fundamentally in over 2 decades. One main drug, modest effect, doesn't stop progression.
And a key barrier mentioned is just not understanding the fundamental molecular basis for cognitive decline, and maybe for Parkinson's overall.
Exactly. That lack of basic understanding hinders targeted drug development. Biomarkers, novel targets, that's where hope lies for better understanding. For depression, lots of trials, but no big comparison, so prescribing is pragmatic.
For anxiety, the big gap is the lack of trials in PD patients.
Right. We rely on general population data, which might not fully apply due to different mechanisms or tolerance in PD. We urgently need PD-specific anxiety trials.
Apathy seems particularly complex and poorly understood.
It really is. Only 2 drugs with modest efficacy. The idea mentioned in the review about maybe targeting different subtypes of apathy, like emotional blunting versus lack of spontaneous action, is interesting for future research and personalized treatment.
And ICDs represent that classic rock in a hard place scenario. Reduce the drug causing the problem, but risk DAWs or motor worsening.
A really difficult balancing act. Often requires combining strategies, strong caregiver support, maybe psychiatric input, and frequently involves using adjunctive meds off-label. It's one of the biggest challenges.
The review is upfront about being a narrative review, not systematic.
Which is true. But given the limited high-quality treatment studies for many of these symptoms, a lot of management does rely on experience in this kind of overview. So a narrative review is still valuable for summarizing the state of play and highlighting those critical research gaps.
It really underscores that despite progress, the treatment gap is significant. Limited effective drugs, modest success rates, non-pharmacological strategies are important, but they don't fill the gap entirely.
And the complexity of the brain circuits involved, plus our limited molecular understanding, are the major roadblocks to designing better trials and finding new targets.
So the key takeaway from this deep dive seems to be, we recognize the huge burden of neuropsychiatric symptoms in Parkinson's disease, but finding truly effective targeted treatments remains a major hurdle, highlighting an urgent need for deeper biological understanding and focused research.
Which leaves us with a thought for you, the listener. Considering this complex interplay, not just between the different neuropsychiatric symptoms, but also their frequent links to motor fluctuations, how might future research better integrate these facets to develop more holistic, more personalized treatment strategies for individuals living with Parkinson's disease?
A critical question. Thank you for exploring this incredibly important and challenging area with us in this deep dive.